Hello, everybody. Today's topic of discussion is percutaneous tracheostomy. Tracheostomy is the surgically created airway that is kept open with breathing tube or tracheostomy tube. Tube is inserted directly into the trachea through an incision into the nape. Tracheostomy can be created with open surgical or percutaneous dilatation technique and can place in the operating room or at patient's bedside. Open technique involves the dissection of anterior pretracheal tissue and insertion of tracheostomy tube under direct vision. The percutaneous technique can be performed quickly and safely at bedside with the use of modified Seldinger technique and bronchoscopic guidance. This approach is associated with fewer bleeding complications than open tracheostomy and similar long-term morbidity. Indications and contraindication. Tracheostomy should be considered in patients with acute respiratory failure who require prolonged mechanical ventilation, defines as ventilation for 7 days or more, and who are expected to have meaningful recovery. Tracheostomy decreases the need for sedation and facilitate weaning from the ventilator. Additional indications include upper airway obstruction, including vocal cord paralysis, the need for airway protection in patients with conditions such as neurologic disease or traumatic brain injury, need for more effective pulmonary hygiene, including the use of recruitment maneuver and methods for cleaning the airway of secretions. Neither previous tracheostomy nor other type of neck surgery are contraindication. In fact, percutaneous tracheostomy may be preferred in patients whose surgical planes have been distorted. Absolute contraindication to percutaneous tracheostomy include cervical instability, uncontrolled coagulopathy, and infection at the plan's insertion site. Relative contraindications include difficult anatomy like short airway, morbid obesity, minimal neck extension or tracheal deviation, and severe respiratory disease resulting in the inability to withstand periods of apnea or in loss of positive pressure ventilation. Now the procedural modifications in the patient with COVID-19. Percutaneous tracheostomy in patient with the coronavirus disease 2019 include the use of complete neurovascular paralysis to minimize the cough reflex and involves the period of apnea when ventilatory circuit is considered to be open. The procedure requires highly specialized team that minimize the number of persons needed and the use of full personal protective equipment. Performance of bedside tracheostomy requires medications for sedation and paralysis. A flexible bronchoscope, preferably a video bronchoscope, since it allows all persons in the room to visualize position of oral endotracheal tube. A bronchoscope attachment for ventilator silicone lubricant, which allows the bronchoscope to pass easily down the oral endotracheal tube. Saline surgical lubricant and dissecting tool, that is tonsil forceps or curved hemostat. Tracheostomy tube, tracheostomy collar, or percutaneous tracheostomy kit. The kit generally include a number 15 surgical scalpel bed, an introducer needle, a guide wire, small tracheal dilator, protective sheath, a single stage progressive tracheal dilator, a tracheal loading trocar, and small slip tip syringe. The size of tracheostomy tube selected should be appropriate for the patient. Percutaneous tracheostomy kit are designed to be used with specialized tracheostomy tube that loads into the dilator. In practice, however, any tracheostomy tube uh, can be inserted in a percutaneous fashion. A thin, flexible tracheostomy tube is useful because it maximizes the diameter of airway while minimizing the pressure on the trachea. Regarding preparation, minimizing the exposure of the healthcare person to aerosol generating procedures is critical when treating patient with COVID-19. To safely perform percutaneous tracheostomy, a minimum of 3 medical personnel may be present: the bedside surgeon, bronchoscopist, and respiratory therapist. Percutaneous tracheostomy is considered to be an aerosol generating procedure. All persons in the room must be wearing personal protective equipment and should observe the policies at their institution regarding the use of PPE during aerosol generating procedures. Now, regarding patient and provider position, the patient should be placed in supine position. The placement of shoulder roll beneath the patient's scapula can help to extend the neck and improve the exposure of the anterior neck. The patient's head should be supported by towel and small pillow if needed. The surgeon should be able to comfortably access the patient's neck while standing. The height of bed should be adjusted as needed. Team members should be positioned around the bed in a manner that allows them to carry out the necessary procedures safely, effectively, and efficiently. The respiratory therapy should stand at the head end of the bed, position that allows the direct control of airway and provides access to the ventilator. The bronchoscopy should be positioned at patient's left side next to bronchoscopy card and video monitor. Although surgeon is generally positioned on the patient's right side with direct view of the bronchoscopy monitor, left-handed surgeon may prefer to be on the patient's left side and bronchoscopist on the right side. Identification of anatomical land. Palpate the neck to identify key anatomical land. These include thyroid cartilage, cricoid cartilage, and the sternal ridge. The ideal location for placement of the tracheostomy tube is between the second and third tracheal ring. Palpate the neck to identify the pulse of high-riding innominate artery that may overlie the area of planned incision. Open tracheostomy is preferred in patients with high-riding innominate artery. So this is the figure 1, which shows the tracheal anatomy and the location for placement of tracheostomy tube. The ideal location for the placement of tracheostomy tube is between the second and third cricoid cartilage. Regarding procedure, before starting the procedure, team should take a time out to verify patients identify and the procedure to be performed. After the timeout, patient's nurse should administer short-acting paralytic agent and if necessarily addition sedation. Inadequate paralysis increases the risk of inadvertent extubation when oral endotracheal tube is being managed. After administering agent, the nurse should step out of the room to minimize the exposure, but should immediately available and ready to re-enter the room if assistance is needed. Sterilize and drape the anterior neck, making sure that the draping will allow easy access to oral endotracheal tube. Make 2 to 3 centimeter vertical incision in the neck that directly overlies the trachea and below the cricoid cartilage. Then bluntly dissect the pretracheal tissue with dissecting tool until the trachea is palpable. In patients who require therapeutic anticoagulation or in whom there is risk of bleeding, it may be advisable to place purse string suture around the tracheostomy incision. The purse string suture is placed but not tied during this step. It will be tied to provide additional hemostatic control once tracheostomy tube has been inserted. The suture is generally removed on second postoperative day if there is no evidence of bleeding. Tracheostomy tube itself should not be sutured in place. Suturing tracheostomy tube results in skin ulceration and does not prevent inadvertent decantation. Ask the respiratory therapist to induce the apnea by placing ventilator on stand. Then disconnect the oral endotracheal tube from ventilator circuit and attach bronchoscope adapter to the tube. Insert the bronchoscope into the adapter, reconnect the circuit and resume the ventilation. Advance the bronchoscope into the airway, briefly survey the trachea and clear any obstructing secretions. Once all team members are ready to proceed, advance the bronchoscope into oral endotracheal tube until the camera is aligned with the end of the tube. At that point, respiratory therapy should again induce apnea and then deflate the tube cuff. The respiratory therapist and bronchoscopist should together then slowly withdraw the tube and bronchoscope simultaneously until subglottic landmarks are visible. Palpation of the anterior trachea by surgeon can facilitate identification of this land. Some practitioners use the transillumination, that is visualization of the bronchoscopic light through the skin to facilitate position of the tube. Bronchoscope is kept within the oral endotracheal tube at all times to ensure control of the airway. Precise communication and coordination between the respiratory therapist and bronchoscopist are the crucial to prevention of accidental extubation. Once the oral endotracheal tube has been withdrawn to an appropriate location, perform tracheostomy using Seldinger technique. Insert the introducer needle through anterior wall of the trachea under direct bronchoscopic visualization. The needle should be inserted at the level of second tracheal ring, perpendicular to the trachea with the bevel falsi facing down. Placement of the needle bevel in this downward position will help to direct the guide wire into distal trachea. It is critical to avoid damaging the balloon on the oral endotracheal tube. In the event that patient's condition becomes clinically unstable or there is difficulty performing the tracheostomy, as long as balloon is intact, the oral endotracheal tube is simply advanced to its original location and normal ventilation is reached. Additional supplies and person can be gathered. If balloon is compromised and its so too is ability to provide positive pressure ventilation. A new airway must be expeditiously established by means of either tracheostomy or oral endotracheal intubation with intact. If balloon is compromised so as to uh, so too is ability to provide positive pressure ventilation. New airway must be expeditiously established by means of either tracheostomy or oral endotracheal tube with intact tube. Feed the guide wire through the needle and visualize it while advancing it distally towards the current. Advance the wire slightly beyond the current. Remove the needle over the wire, keeping the wire in place within the trachea at all times. Then advance the small tracheal dilator over the wire to dilate the tract. Then remove the small tracheal dilator and the protective sheath loaded. Advance the single stage progressive dilator over the wire. Remove the progressive dilator, keeping the wire and protective sheath in place. Marking on side of progressive dilator guide the depth to which it is inserted. Next, insert appropriately sized tracheostomy tube directly into trachea over the wire and protective sheath. If using flexible tracheostomy tube, insert the tube with curve directed towards the patient. Once the tube in the patient's trachea is visualized, rotate the tube 180 degrees. This will position the tube in its normal orientation and prevent it from creating pretracheal plane. Alternatively, a non-flexible tracheostomy tube can be loaded into an insertion trocar and advance over wire and protective sheath into trachea. Once the tube is in place, remove the protective sheath, wire, and trocar. Inflate the tracheostomy tube, connect the circuit to the tracheostomy tube, and resume the ventilation. The presence of end-tidal carbon dioxide confirms the placement into the air. Alternatively, bronchoscope can be reinserted through tracheostomy tube to visually confirm the placement within the air. The position of the tracheostomy should conform with the patient's head inflection and extension. Only then should the oral endotracheal tube can be removed. Once satisfactory placement is confirmed, secure the tracheostomy tube with tracheostomy collar. If purse string suture is placed, tie down the suture to close the skin incision around the tracheostomy. Once the patient is appropriately ventilated through secure tracheostomy tube, oral endotracheal tube may be removed. So this is the figure showing insertion of introducer needle and the guide. The introducer needle and the guide wire are inserted through the anterior wall of the trachea under direct bronchoscopic guidance. This is the picture showing the tracheal dilator. A small tracheal dilator is advanced over the guide wire to dilate the tract, and the small tracheal dilator is removed. The protective sheath uh, is loaded, and the single stage progressive dilator is advanced over the guide. The loss of the airway. The most serious procedural risk associated with endotracheal intubation is loss of airway. This typically occurs in one of the tubes. The patient coughs during manipulation of endotracheal tube or balloon and the tube is damaged. Adequate neuromuscular paralysis should prevent the patient from coughing. An intact balloon is critical to safety of the procedure. If the patient's condition becomes unstable or if there is difficulty placing tracheostomy, the oral endotracheal tube should be advanced to its original location and ventilation resumed. If the balloon is compromised, the provision of positive pressure ventilation is compromised. Either a new airway must be established expeditiously by creating tracheostomy or replacing compromised endotracheal tube with intact tube through oral endotracheal intubation. Then aftercare. In immediate postoperative care, the tracheal stoma requires regular assessment, wound management, including frequent cleaning of skin around the stoma and change in dressing as needed. Pulmonary hygiene, ventilator weaning, and eventual decannulation should be performed in accordance with institutional guideline and clinical status of the patient. Maturation of tracheostoma occurs after approximately 7 days, at which time the tracheostomy tube may be replaced or downsized, depending on the clinical need of the patient. The surgical team typically perform the first such exchange. In patients with COVID-19, the focus of early post-procedural care is to ensure minimization of aerosol generation. Effective measures include keeping the cuff inflated, using closed suction catheter when clearing the airway, if possible, avoiding the use of humidified oxygen. Ideally, deflation of the cuff, replacement of the tracheostomy tube, and the initiation of plan for decannulation should be deferred until the result of patient testing for COVID-19 are negative. Regarding complication, early complication after placement of tracheostomy tube include bleeding and obstruction and dislodgement of tracheostomy tube. Bleeding is most common complication, but it is usually self-limited or can be controlled with the use of measures such as application of the pressure or the use of hemostatic agent. Bursting method described above may help to control bleeding from the skin. In adult decannulation and obstruction of tracheostomy tube are rare, but should they occur, both can managed by securing airway through oral endotracheal intubation. If obstruction of the tube cannot be cleared with standard suctioning technique, or if the tube become dislodged, the airway should be secured by means of orotracheal intubation. Insertion of new tracheostomy tube through tract that has not fully matured should not be attempted. Local complications after tracheostomy include tracheoinnominate fistula, tracheoesophageal fistula, and tracheal stenosis. The development of fistula is a rare complication that requires surgical consultation. Tracheoinnominate fistula are rare and life-threatening. If fistula is suspected, immediate operative repair must be performed as it affords the only chance of survival. Tracheoesophageal fistula typically occurs in patients with esophageal foreign body, such as feeding. Operative repair is indicated after the patient's critical illness has resolved. Tracheal stenosis can occur anywhere along the trachea, from tracheal stoma to cuff of the tracheostomy tube. Stomal stenosis results from the trauma of tube insertion and excessive movement at entry. Cuff stenosis is related to the mucosal ischemic injury from high cuff pressure. Tracheal dilation is a palliative and definitive treatment requires resection and reconstruction. Thank you guys.